to Sarah.
Yep.
So these are my disclosures. So pancreatic cysts are precursors for pancreatic adenocarcinoma. About 15 to 20% of pancreatic cancers are attributable to mucinous cysts, specifically IPMNs, and we have had a good introduction session. Despite innovations and progress in diagnostics, several recent surgical series reveal a high percentage of resection of benign neoplasms, such as serous adenoma, as seen in this picture. Further, the resection rates of branch duct IPMNs with low-grade dysplasia also tend to be high. Branch duct IPMNs are the most common resected pancreatic cystic lesions. Ideally, we want to selectively resect only those with advanced neoplasia, that's presence of high-grade dysplasia or adenocarcinoma. Despite guideline-based management, recent surgical series, as shown in this picture in the last decade, show that nearly 40 to 60% of resected branch duct IPMNs reveal only low-grade dysplasia. There is considerable postoperative morbidity following pancreatic surgeries. In the AGA technical review, the pooled mortality was 2% and morbidity was about 30%. Now, here is a study looking at the postoperative complications in those with branch duct IPMN and low-grade dysplasia. In this study involving 3 US NCI designated centers, nearly 51% of branch duct IPMs resected were of low-grade dysplasia. Amongst this, nearly 50% had surgical complications and 1/4 developed diabetes. Appropriately so, this paper by the surgeons was titled Surgical Overtreatment of IPMNs. And they concluded that there is a critical need to improve diagnostics and risk stratification of IPMNs. So the diagnosis of pancreatic cystic lesions is a two-step problem. Dr. Park briefly alluded to that in the previous talk. Step one is primary differentiation of pancreatic cysts as mucinous versus non-mucinous. With standard of care, which includes cyst morphology, cyst fluid CEA, cytology, the accuracy is below 70%. Once you diagnose a mucinous cyst, the most common of which is a branch duct IPMN, further risk stratification is problematic. With current guideline-based management, the preoperative accuracy is below 65%. So we're going to discuss about revival of cyst glucose briefly again, and then discuss novel technologies. Cyst glucose is better than CEA or cytology. In a pooled analysis, the sensitivity is 90%, specificity 85%. For lower values of cyst glucose below 50 milligram per deciliter, that's diagnostic of a mucinous lesion. So you are back to this two-problem chart. When you add cyst glucose, the accuracy goes up to 90% in differentiating mucinous and non-mucinous lesions. But that still leaves you with the problem where, in case you diagnose a branch duct IPM or a mucinous cyst, we are unable to risk stratify these lesions. This takes us to this discussion about novel diagnostics. The first is genomics, which is cyst fluid molecular analysis. As discussed in the previous talk, next-gen sequencing analysis is the most reliable, has the most robust data. You require a very low volume. A 22-gauge needle is sufficient to aspirate the fluid, and the risk of acute pancreatitis is almost negligible. However, got to note that it requires specialized labs with validation of the sequencing analysis. The established cyst fluid molecular markers are shown in this figure. Over the last decade, there has been continued innovation with discovery of novel molecular markers that have a high specificity for diagnosis of specific cyst types and also for the risk stratification of branch duct IPMNs. I had the opportunity to discuss the recent study results with Dr. Arthur Singhi. Here is a recent update from the multi-center prospective study from the University of Pittsburgh. Among 251 surgical resections, the sensitivity was 90% and specificity 100% for the differentiation of pancreatic cyst to mucinous and non-mucinous lesions. For detecting advanced neoplasia in mucinous cysts, the sensitivity was 88% and specificity 95%. These parameters to detect advanced neoplasia in IPMNs, when combined with cyst cytology, improved the sensitivity to 93%. The next technology is digital pathomics. because you get quantifiable variables using needle-based confocal laser endomicroscopy. For EUS endomicroscopy, we use a 19-gauge needle that is preloaded with the endomicroscopy mini probe. Once the cyst is punctured by the needle, the mini probe is actuated beyond the tip of the needle to obtain in vivo histology of the PCL or cyst epithelium. The newer model of the endomicroscopy processor is more compact than the prior generation. I want to briefly discuss the various endomicroscopy patterns. Here is a stepwise process to diagnose pancreatic cysts using endomicroscopy. The first step is to detect the presence of papillae or epithelial bands. That's diagnostic of a mucinous cyst. Papillae or finger-like projections with a vascular core, diagnostic of IPMNs. Whereas epithelial bands are flat and are seen in both MCNs and also IPMNs with low-grade dysplasia. In the absence of these patterns, the next step is to look for cards or groups of cells separated by the stroma of the cyst. This is diagnostic of a neuroendocrine tumor, cystic neuroendocrine tumor, or a solid pseudopapillary neoplasm, and you would need immunostaining to separate between those two. If these epithelial patterns are not observed, you have to look for a vascular pattern that is a dense capillary network called the superficial vascular network, or the Fern pattern of vascularity, which is diagnostic of a serous adenoma. If you don't see any of these epithelial or vascular patterns, if you just see a dark background with bright, shiny particles, which is autofluorescence from inflammatory cells, this is most suggestive of a pseudocyst. After the discovery of endomicroscopy patterns of mucinous cystic neoplasms by Dr. Napoleon and his group, the more recent studies with a larger enrollment have consistently shown a high level of diagnostic accuracy to differentiate cysts as mucinous or non-mucinous using endomicroscopy. EUS endomicroscopy can detect advanced neoplasia in IPMNs. In this figure, the top panel reveals endomicroscopy and corresponding histopathology. The papillary epithelium is flat and translucent, and with progressive dysplasia as shown in the bottom panel, the epithelium is darker and thicker, indicative of nuclear and cellular stratification. Among blinded human observers, we have shown that endomicroscopy achieved a high degree of accuracy for risk stratifying IPMNs. These variables of epithelial thickness and darkness are quantifiable. We have built and published a preliminary artificial intelligence model that has performed well with an accuracy of above 80%, and we continue to investigate this further and improve the AI-guided risk stratification of branch duct IPMNs. The overall risk of post-procedure acute pancreatitis for EUS endomicroscopy is about 2.2% across all these published studies with nearly 550 patients. All these episodes of acute pancreatitis were of the mild severity. One study, though, used endomicroscopy and the older generation of spyglass, having a higher rate of pancreatitis. The next modality is EUS guided through the needle biopsy or microforceps biopsy. The microforceps biopsy is loaded through a 19-gauge needle. In the last 2 years, we have seen multiple meta-analysis using EUS through the needle biopsy, and a majority of them based on retrospective data. Compiling this meta-analysis, the overall number of forceps passes required to achieve a diagnostic adequacy is between 3 and 4 passes. To differentiate cysts into mucinous versus non-mucinous lesions, the sensitivity is about 90% and specificity 95%. The diagnostic yield for specific cyst type is about 70 to 80%. Microbiopsy has the potential to subtype IPMN as gastric, intestinal, pancreatobiliary, but then the gastric is the most prevalent. So to really establish that, we will need large studies. We can potentially risk stratify IPMNs using biopsy and also sending the material for next-gen sequencing. But note that the apparatus with 19-gauge and the microbiopsy has markedly reduced maneuverability, limiting the range of the biopsy. Biopsies tend to be very focal. Now, through the needle biopsy has a high risk of adverse events. In this most recent publication, just came out last month, investigators analyzed 500 microbiopsy procedures from 10 centers. The mean size of the cyst was 3.7 centimeters. The overall risk of any adverse event was 11.5%, and the risk of adverse event in IPMNs was 28%. These adverse events included acute pancreatitis, fever and infection, and clinically significant intracystic bleeding. In a multivariate analysis model for the outcome of adverse event, IPMN was the strongest predictor with the odds ratio of 4.6. Further, there were 3 deaths in this study with a fatality rate of 0.5%. And this is despite 1/3 of the patients getting rectal NSAIDs. So, to use microbiopsy, you have to really weigh the benefit versus the risk, and you have to carefully select patients. Here is a comparison of all the novel modalities. Mucinous cystic neoplasms tend to have wide areas of atrophic epithelium or chronic inflammatory epithelium, and they pose the biggest diagnostic challenge across all 3 modalities. For cyst fluid molecular analysis, there is a need to improve the sensitivity for detecting VHL mutations diagnostic of serous cyst adenoma, and we need markers for cystic neuroendocrine tumors. EUS endomicroscopy has a learning curve, not only for getting the current technique, but also for being familiar with the image patterns. Through the needle biopsy provides really microbiopsies. You have to discuss with your GI pathologist, and we generally tend to use tissue filters during processing the specimen. For the detection of advanced neoplasia, published data is supportive of both cyst fluid molecular analysis and endomicroscopy. Note that microbiopsy has the highest risk of adverse events, specifically about IPMNs having a 28% risk of adverse events in microbiopsy. Stressing the fact that we are surgically overtreating branch-duct IPMNs, we need complementary and integrative AI mechanisms that incorporate standard of care variables, that's including all the guidelines, endomicroscopy, radiomics, which is the texture analysis of MRI and CT, and next-gen sequencing analysis of cyst fluid. If we use all these variables, there will be a day in the future where we can accurately risk stratify IPMNs and avoid unwarranted surgeries. In conclusion, cyst fluid glucose is economical and improves cyst differentiation into mucinous and non-mucinous lesions. However, note that your labs needs to validate the marker before clinical application. Both next-gen sequencing and endomicroscopy have a strong potential to safely risk stratify branch duct IPMNs. Through the needle biopsy has high risk of adverse events, specifically for IPMNs, so you need to weigh the risk versus benefit. We are currently surgically overtreating branch duct IPMNs, and efforts have to continue to reduce pancreatic surgeries for those with low-grade dysplasia. At the same time, we should not miss lesions with advanced neoplasia. So at the end, evaluating a pancreatic cystic lesion depends on the endoscopist and center's experience and expertise. Many a times, you need most of these puzzle pieces to make the best decision for the patient. And I'm grateful and thankful to all the society, industry, and institutional funding which have propelled our CYST projects. Thank you.
So I know we're going to do a panel discussion.